Before we get into the weeds a little bit, cell-free DNA and circulating tumor DNA are two different species that we have in the blood. You get fragments of DNA found in all extracellular fluid compartments in blood, urine, all sorts of body fluids, and they're usually released by cells due to apoptosis or by necrosis. Circulating tumor DNA is associated with a large swath of malignancies. We talk about prostate cancer and breast cancer and colorectal cancer, to name a few. But the interesting thing is you can have a lot of cell-free DNA circulating out there that is not associated with a tumor, but trauma, cerebral infarction, exercise, infection, you can have cell-free DNA, which is not malignant DNA. It's normal DNA that's just released out into the bloodstream. And in healthy individuals, most of the cell-free DNA comes from the hematopoietic cells. And not to get in the weeds too much, but when you do these assays, you have to make sure that when you're measuring circulating tumor DNA, you're not picking up a signal from hematopoietic cells. And that is a technicality when you're actually doing studies of circulating tumor DNA. Here was our ancient work that I like to talk about whenever we talk about circulating factors. And what we did was very simple. We just took 6 cc's of blood. We spun it on a Ficol gradient in the monocyte level. We extracted RNA for RT-PCR. Well, this has certainly exploded over the years now. And again, relative to our talk today, prostate and bladder cancer, there's exosomes, circulating tumor DNA, circulating tumor RNA, and CTCs, to just name a few. This was just a review article with a little bit more complete graphic of what's going on with circulating tumor DNA, with the apoptosis, necrosis, and actually tumor shedding into the circulation. And again, it's usually picked up in the monocyte level when you spin the cells down. So very interesting. Back at the EAU in 21, sort of after COVID, there was this very nice graphic that indicated that circulating tumor DNA has a great potential to be used throughout bladder cancer, and whether it's for early detection, risk measurement, treatment selection, efficacy, and certainly post-treatment care. But again, very interesting on how this has really taken over. There have been a boatload of tests that have looked at circulating tumor DNA in the urothelial carcinoma. And what you tend to see is that depending on what the assay that you're looking at, you may not get the same molecular profile. So sometimes you got to be very specific what you're looking for when you pick out the sequencing method. And you can see here there's many different sequencing methods out there. So this is not one size fits all. You really have to get again into a lot of the technicalities about what genes you're looking for and what's the best sequencing method to pick the circulating tumor DNA. So I think where we are right now in circulating tumor DNA is the topic really is looking at minimal residual disease detection and adjuvant treatment. This is what's gotten the most interest lately in the certainly in the medical oncology community with the IMvigor 10, and then now the follow-up IMvigor 0111. It's the minimal residual disease that's really most helpful in deciding who benefits from adjuvant therapy. So here's what's happening from a practical standpoint in the studies that we're going to talk about. Bladder cancer patient comes in, has the TUR, has the radical cystectomy. Post-operatively, blood is collected looking for circulating tumor DNA. If it's negative, the patient is just observed. However, it continues to be positive after the radical cystectomy, then they are randomized to either treatment with immunotherapy. Most of the trials look at immunotherapy, or just simply surveillance. So this is not a real case, but this is just sort of a mock-up of a patient who has undergone treatment with neoadjuvant chemotherapy, then followed by adjuvant immunotherapy. And again, here, if you look at the circulating tumor DNA analysis, you can see that with each cycle of adjuvant immunotherapy, the circulating tumor DNA burden goes down and down. Again, this is just a theoretical example, but this is the direction all of the studies are going in. So this was presented at EAU, and this looked at the IMvigor 010 study looking at survival by circulating tumor DNA, and this was the original trial. It looked at adjuvant tislelizumab versus observation, and the original trial actually did not show an improvement in outcomes with treatment with the atezo in the adjuvant setting. However, when they started to look a little bit more about circulating tumor DNA, they came out with something that was very interesting. They were able to show that in a retrospective analysis that circulating tumor DNA after radical cystectomy may actually predict the outcomes and predict the IO therapy outcomes. So here you see circulating tumor DNA negative, much higher likelihood of having a disease-free survival as opposed to the patients who were circulating tumor DNA positive. And again, looking at patients who are positive versus negative, again, very impressive difference in survival. And this is overall survival. If you're circulating tumor DNA positive versus circulating tumor DNA negative, you're at a much higher risk of relapse. And again, if you were treated with the atezo, you had a much higher likelihood of having a extended survival, even if you were not as good if you were circulating tumor DNA negative, but you got some improvement if you were circulating tumor DNA positive. So positive patients in this study, the clearance was if you cleared the cells with each cycle, you had an improved overall survival. And I think this is very, very, very impressive as a marker. When we would do radical cystectomies on people, we would never know why certain patients recurred and other persons didn't recur. It's clear that you had circulating factors out there that were probably taking up residence someplace else in the metastatic setting. So based on that, the IMvigor 011 trial is strictly focused on circulating tumor DNA positive, high-risk muscle-invasive bladder cancer, and again, looking at the atezo versus the placebo. But it will all be driven now by circulating tumor DNA outcomes. So with longer follow-up in the original IMvigor 010 trial, the circulating tumor DNA positive status continued to identify patients at high risk of relapse. And again, the IMvigor trial is the 011 is going to look at this answer more closely. Lastly, another related trial that looked at circulating tumor DNA was the Keynote trial looking at Pembro or chemotherapy-based adjuvant following radical cystectomy. And again, the patients either got Pembro, they got Pembro plus chemo or chemotherapy alone, but this specifically spent a lot of time looking at the circulating tumor DNA substates. I show you this because I'm hoping maybe somebody smart like Dr. Petrolak can figure this out. They came up with these circulating tumor DNA measures, maximum, mean, tumor-informed, guardian health. I don't really understand it, but it was very important in their study to look at these different assessments of circulating tumor DNA. And again, the overall survival, as you can see, was actually improved with the Pembro. However, it was interesting when they actually did the study. They got better clearance of the circulating tumor cells with chemotherapy as opposed to the Pembro. And that was pretty consistent all the way through the different trials. However, it turned out that the overall survival, when it was all said and done, was better with the Pembro. So there's some It's almost like the chemotherapy whacks all the circulating tumor cells or the circulating factors early, and then really the Pembro works more long-term to do more cleanup that the chemotherapy misses. So again, this was also a retrospective analysis of this Pembro-based trial. And what was very interesting, if you think about it, most of their patients were positive for circulating tumor DNA at baseline. And again, the changes with the Pembro were more associated with long-term improved overall outcomes. And then when you got involved with tumor mutational burden and PD-1 and PD-L1 levels, you got more information. And lastly, this is fascinating to me. They're now looking at cell-free DNA assays in the urine. So this is not only for patients with localized disease, but apparently with also a disease burden, circulating cell-free DNA. You apparently shed this in your into your urine as well. So this is another area that's going to start to take off. So again, if you look at the urine and the circulating circulating tumor DNA, you can see that there's some differences. There's a lot of similarities, but you also pick up a different pattern. What that actually means, I don't know, but this is a very early study looking at circulating tumor DNA in the urine, and it may become an assay that's more common in the future. And whenever we talk about urine, as urologists, we have to remember that urine was the original liquid biopsy that goes back to the 1300s and 1400s, where the urine, what they would call them, I think urinoscopists or something like that, would actually go around and collect urine, and they would give you a health assessment based on what the color of your urine was. So again, this stuff seems to be new, but it's actually been around for a long time. So anyway, thank you all very much.